carina, above the carina. So this is what of course, we have the experience with such a small babies. And my first intention was to do the whole surgery today. But because the baby is not very stable, so we will limit our procedure just only to close the fistula. And the next stage we will do a few days later. Okay. Sorry. Naciśnij jeszcze raz. Okay. So we are ready. Możemy zaczynać. Słuchajcie. Pani Natalko. To co, będziemy potrzebowali noc? Okay. So, mogę mieć pisaka? Nie, jest dobrze, Piotruś, jest dobrze. So just to show everyone how we place the trocars. So this is the scapula. So the baby is completely in a prone position. This is the vertebra. So the first trocar is just below the tip of the scapula, about 1 centimeter below. Another one we will put halfway between the vertebra and the first one, so somewhere here. And the third one we'll put at the axillary, posterior axillary line, high into the axillary fossa. So it looks like this. Okay, so we start with the skin incision with the 11 blade. That's perfect for every endoscopic procedure. I like it. Then we put a small hemostat into the chest, so I don't use a Veress needle. Okay, so we are already in the chest. And then we use a 5 millimeter trocar that is with a blunt tip. As you can see, there is the rubber around the trocar just to fix it to the skin. So we know this is very small baby, so we are very gentle. Okay, so we are already inside. We will change the rubber to a smaller one because we are using a short scope, 4 millimeter. Well, let's start with insufflation. The insufflation pressure is 6 millimeter and 1.5 liter of flow. That's very important, especially for such baby to have a heater, because if you have a lot of gas losses, so it's better to heat it just to prevent the baby. Okay, can we secure it, Chef? So this is how we fix the trocar. There is nothing more frustrating than fighting with trocars that are going out and in. So that's very important to prepare everything. Usually when we start with the insufflation, there is some drop in saturation, how it is. But it's not true today because the baby has 100% of saturation, so doing fine.
In progress.
Okay, let's go. Już jest, Otmar. So our anesthesiologist, we have a great team today. Was a little bit surprised that we already started with insufflation and there was no drop in saturation. Okay, so we are already in the chest. As you can see, right now we have almost no space. Chyba nie dmucha jeszcze. Okay, the insufflator was not switched on. Right now you can see that the lung is going down. Okay. That's a usual story that the lung stick to the pleura. So just wait a moment, find a good place to take it down with the tip of the scope. You will see at the moment, yeah, that's it. You can see the hugely dilated the distal pouch. This is this. This is, we can even see perfectly the fistula side. You can see it here, how it is very distended. Okay, keep the camera. Nóż. So right now I will put 2 other trocars, trocar od razu. Okay, there are 3 millimeter trocars. Okay, that's fair. Okay, you can see one, another one. That's very difficult to place the trocar that is in the axillary fossa. You have to go under the scapula and then enter the chest, like here. Suture. Będziemy potrzebowali 3,0 na podwiązanie przytoki, 10 cm, dobrze, bez igły. Może mi pani z tego odciąć, co to jest? To nie. Dobra. Probably the fastest way is to clip the fistula. But the only problem is that you need to use a 5 mm trocar. We will check if you have a problem, we will exchange it to do it faster. Potrzebuję dissektor i grasper. Nożyczki. This is what we like to do, to put some lubrication on the instruments to have a free movement. So because we know already from the bronchoscopy that the fistula is on the posterior wall of the chest, it's usually in such a situation that we start with the dissection above the azygos. That for us it's a landmark. Mogę troszeczkę ucisnąć tchawicę, jakby coś. Krzyczcie, dobrze, gdyby coś było. A będę miał taki ten szapi, czy nie? So as you can see, this is just only blunt dissection. Czy mamy sondę w tym, czy nie mamy? To nie będziemy zakładać. Nie. I will not go up. Probably the upper pouch is somewhere here. Oh yes, we can see it. But we will not do today it. Okay. Proszę mi dać to drugie narządko.
Derek.
Yes, Mario.
Yes, because there is many colleague that is connected now. You repeat what is the reason of your strategy of your closed only the fistula.
Yeah, the baby is not doing very fine. So this is why we decide to do it in stages. Proszę mi dać ten imadło z nitką. So this is why we'll not do today the anastomosis. And the baby is very small. It's a premature baby. So we would like to improve it with the respiratory conditions. So this is why today we will not do any anastomosis, just only ligate the fistula to shorten the procedure. And we'll do it next on Monday or something like that, okay?
I think that is very important, Derek, because we see very near the upper pouch.
Yeah.
And remember, don't surgical narcissism before is the neonates.
Yeah, that's it. What we decided to do it in this way. I think it's very important. Mogę mieć tego zakrzywionego takiego 24, 22. Yeah, you know, that's the advantage of minimal invasive surgery, that you can go into the chest again without too much harmful procedure for the baby. Okay. The only what I would like to do, I would like to dissect it a little bit more up. You can see that we are at the level of the trachea. Dobrze, to co, poproszę teraz imadełko. Of course, what we will do a sliding knot as usually. And you will see the advantage of sliding knot when you ligate the fistula. That's very important to be at the level of the trachea. So with a sliding knot, it's much easier. I will show you the trick at the moment. No, we are. That's the question about whether we are going to do the gastrostomy. No, in this case, we are not going to do the gastrostomy because I think that in a few days we will come back, so we can keep the baby on TPN for a few days. So I don't think that this is necessary to perform another one procedure. If we in a few days we will do the esophageal anastomosis. Okay, so now you can see. Mogę mieć ten Szapi? That's a trick that we use to put the ligation just at the level of the trachea. You will see at the moment. So you can see that right now I take it up and I take the loop to another one direction. Okay, right now it looks that it is on the level of trachea. Yeah. Dissektor. Mamy podwiązaną przytokę. Okay, so the fistula is ligated, you know, and I know a lot of stories from people who just only ligated the fistula that it will recurrent in 2 or 3 weeks. But we are not going to wait so long, so I don't afraid about it. So this is why I don't cut it. And because sometimes if we have some tension, the distance between the upper and lower pouch, we could put the traction just taking them together. But in this case, it shouldn't be any problem. So we'll do nothing more, just only cut. And this is the end of our procedure. We will send baby back to the NICU. And then we will come back on Tuesday, on Monday or Tuesday. I will let you know and you will see our procedure. That's the end of the procedure. Okay, stop gas, stop insufflation. Okay, we desufflate the pleural cavity. We'll put no drain. As you can see, there was no hemorrhage. It was completely bloodless procedure.
Darek,
Yes?
why you don't use a transfixed stitch and you prefer only ligation for closing the fistula?
Okay, Mario, the only limitation for me not to put a clip is that you need to use a 5mm trocar. That's the only reason, nothing more. Nothing more. And for me, ligation is almost the same like placing the clip. May I have a drain? So this is why I ligate it, you know? Because anyway, even that I want to put a clip, I have to dissect the fistula around. So for me, it makes just 1 minute more for the procedure. So this is why I ligate it, okay? So as you can see, we will, right now, we put a drain into the chest and we will ask our anesthesiologist to expand lungs. And with the final stitch, we'll take the drain out. That's okay?
Yes, there is a question from the audience.
Yes.
The question is, do you perform gastrostomy? But you have said before, and do you keep baby paralyzed?
I don't think that for this, our anesthesiologists are very against paralyzing the baby. So we don't use it. We only use muscle relaxant if we have a long gap with, you know, internal traction or a very difficult anastomosis with a lot of tension. So in such a case, we would like to keep the baby paralyzed for 2 or 3 days. But for this case, there is no indication. There is no indication to have the baby paralyzed. We just only want to improve the respiration. So this is why we'll wait 2 or 3 days, or maybe up to 1 week, and we'll come back. We have around, I cannot say exactly, but probably around 10 cases of type C that we couldn't do in one stage because of instability. So in such a situation, we just only close the fistula and come back within a few days. Okay? Możemy poprosić o rozmuchanie płuc?
Darek, a question
Push
for
the
the
bottle for that.
anesthesiologist.
Yes?
What I want to ask to your anesthesiologist is if you have a change of parametry of when you do the pneumothorax.
Did you change, zmieniła pani parametry? Proszę tu mówić do mikrofonu, jak można, pani doktor. Okay?
I didn't listen.
Okay, the question was whether you change any ventilation parameter when we started with insufflation.
Inspiration.
Okay.
We don't hear what.
Okay, so I
If
will,
you
I
want
will
to
repeat.
repeat, please.
You, okay, Mario? So this is the answer from my excellent anesthesiologist team, that they increase the insufflation pressure and just the rate of ventilation, but the saturation was almost above 90%.
Okay, thank you very much.
Yeah, okay. Okay, and also the oxygen, but right now it's 25% of oxygen, so it's not so bad. Proszę rozbuchać płuca. Okay, so right now we expand the lungs, we put the drain under the water, there is no bubble, so we take the drain out, and we put our final stitch on it, and that's the end of the procedure, okay? So thank you very much. As you can see, ligation or closure the fistula with minimal access surgery, it's really very fast. So just think about it. If you have a baby in not so good condition, so in such a case, think about that you can do the procedure in stages, especially having an experience with minimal invasive surgery. Thank you very much for watching.
Thank you,
us.
Darek. And I remember to the 55 colleague what is connected that probably in the next week there is a second step. Yes.
Yes, of course. And we also, Mario, if you let me invite everyone on 16th of July.
No, June.
Sorry, June.
For duodenal. And I want to ask to Adrian that I see that is connected. That
Yes.
is a pleasure if you want participate of duodenal stenosis because Adrian has a very big experience.
It would be great. It would be great to have you on a board. So thank you very much. Thank you. Oh, just a moment. There are 3 more questions I will answer. Yes. Okay, I am coming to the mic, to the camera. Okay. Just a moment. Okay. Okay, you should see me in a moment. Okay, that's me. Okay. Yes, the question was? Okay, for the time to the next procedure, the baby we will give only total parenteral nutrition. So we are not going to do the gastrostomy right now. Okay, for the stabilization, I mean that if there is no problem with ventilation, that's the first, because this is the most important factor for us. And of course, if there is no infection, that's very important. Yeah, so it should be, the weight of, that's my opinion, that there's not too much difference if you have the experience to do 1,500 baby and above with a thoracoscopic approach. For this baby, it would be extremely difficult. But I think that looking at the tissue, how it looks, and the Upper pouch is very close to the distal pouch. It shouldn't be too much problems, but we need very stable patient. Probably we could proceed right now, but in case that something happens, we lost connection. Okay. Can you hear me? It's okay?
Yes, yes,
Okay,
we hear
okay,
you
okay.
perfectly.
Yeah, okay. So we just only lost the picture. So that's my idea. Of course, if baby is not doing fine, we can do the gastrostomy, but we have, a few days more just to make a decision. If the baby is not in a good condition, we'll do the gastrostomy and we'll do the surgery at 1 or 2 months. But I think that having our experience, we can do safely at the next stage. The position, as you at the beginning I explained, this is the way we put the trocars. The trocars are placed around the scapula, so this is our anatomic landmark. So the first one is the posterior axillary line, just around 1 centimeter below the tip of the scapula. The second one is half at the same level, halfway between the vertebra and the first one. And the third one is the axillary fossa, also in the posterior axillary line. But that's very important how you place this trocar. You have to go under the skin, then under the scapula, take your trocar with the scapula up, and then enter the chest. So this is just a trick to have a good access. And this position usually gives you fantastic view of the mediastinum that you have seen, and also a good position of both working instruments, because they are almost in 90-degree angle, and that's, you can manipulate the needle, you have a good direction of the needle. So that's the most optimal for us. I know that some people place the scope just between the vertebra and the scapula, so it means that you are watching from above. But I think that with this position of the trocar, it happens that the scope keep the lung and prevent from entering our view. But usually with the insufflation of 6 millimeter of mercury for newborn, the lung completely collapse. But probably if you, I presented a very special case that we operated 2 years ago that had a right lung agenesis. So it was only one lung, left lung, and we did a thoracoscopy through the left pleural cavity. So the baby was ventilated with only one lung, that the cavity, the pleural cavity was insufflated, and the baby was doing fine. And the baby was doing fine for the whole procedure. So it is possible to do it, yeah. So I think that I answer all your questions. So thank you very much. Yes?
I want to remember to the colleague that was connected late that it's possible to see in the library of our website the video that is recorded, the video of this procedure, and it's possible to see very well what is the position of the trocar when you start your operation, okay?
Okay. Thank you very much once again. Thank you for inviting me, and thank you for watching. Our pleasure to be together with you.
And I send a message for the second stage.
Okay, I will inform you 1 day before, okay? Thank you very much.
Bye-bye. Bye-bye.
Warm regards to all of you. Bye-bye. Już minimum